Is there any question yet from the... Yes?
Yannick Crow and others have claimed that some of these disorders are interferonopathies with very specific profiles, and also that SLE can also be an interferonopathy, and those will be driven by plasmacytoid dendritic cells, which are very difficult to measure in the brain because you only need a few of them. Do you think that's a subtype of depression being interferon-driven? Obviously, your data is by giving interferon, but do you think it's endogenously, SLE, etc., may drive interferonopathies as being a causative factor?
So you're right. This data was obtained in patients who received interferon valve. So interferon was administered exogenously, of course. And we know that there are different other immunotherapies, including interleukin-2 therapies, that also induce depressive symptoms. But we also know that the expression of the symptoms is different. You know, with interferon alpha administration, you primarily have symptoms of, you know, depressed mood, reduced activity, you have a lot of neurovegetative symptoms. You don't have this type of symptoms when you administer interleukin-2 to patients. So unfortunately, you know, when we have a subset of patients with depression, we can do correlation. Most of the correlations that we find with depressive symptoms are obtained with interleukin-6 and CRP. We don't see a lot of correlation with interferon alpha. But, you know, there is such a variability that we don't know, you know, and we know that cytokines works in network, and it's not, we don't expect to see a correlation with specific, you know, measures. What is relevant and important to know is that interferon alpha administration is going to be associated with the activation of the immune system, with the release of other pro-inflammatory cytokines, and including interleukin-6, tumor necrosis factor alpha, and we don't know if it's, you know, really the interferon alpha that induces behavioral change. It may be an intermediary cytokine.
This to Yehuda. I mean, this clearly we look for biomarkers from the blood to detect what's going on at the interface between the immune system and the cognitive system. But in between, there is hematoencephalic barrier. So I was wondering whether there is some data showing that there is alteration in this barrier that will help actually be able to, you know, look in the blood to those differences.
I will answer you as I usually answer my wife. If you would not
This is a promotion for me, I mean, clearly.
If you would not have squeezed me so much, I would already talked about it. But because you are so nice and you have the name Sharon, I will answer it. Yes. Always, when you have CNS involvement in lupus, there is high activity of the disease, no question. And when you have high activity of the disease, there is opening of the blood-brain barrier. And therefore, the penetration of autoantibodies is much more easily. We have found, interestingly enough, that cannabis can close the blood-brain barrier, and we tested it so far in mice. We are planning to give it to mice with CNS involvement. It means that we will inject it peripherally to see if we can close the open blood-brain barrier when there is CNS involvement in lupus. So it might be, if we will have another meeting another year or another 2 years, or during the Congress of Autoimmunity, we might have already results, and we might recommend cannabis to treat actually the blood-brain barrier in those cases.
You'll be very popular in California, where it's now legal to grow cannabis. So. I have actually another question, but not on your wife's side, on my side this time. It concerns, we have evidence in the field of transplantation that, and mostly from the Dutch group of Leiden, that there is cross-reactivity between infectious disease and actually allogenicity, alloreactivity. So you modify the alloreactive repertoire by actually mimicry or cross-reactivity with infection. Clearly, in your scheme, there is genetic factor, environmental factor, and infection that are very important. Is there any data showing actually the change of the T-cell repertoire by the actually infection in those autoimmune neuropsychiatric or more general autoimmune disease?
Thank you. It's a very important question. We don't see changes in T-cell repertoire, but we do see changes in the B cells because the induction is basically by molecular mimicry. Having said that, related to SLE, recently we have found, and we published it, that the papilloma virus, which is found in patients with lupus and causes cervical carcinoma, is the cause of lupus, because there is a higher incidence of papilloma virus before the disease, before the women start with sex and before they get immunosuppression. And we found the homology, molecular mimicry, between the HPV and the disease itself. And therefore, it's very similar to EB virus. EB virus also changed the B cell repertoire, cause autoimmunity, as I mentioned, 33 different autoimmune, but can cause also lymphoma. HPV can cause lupus, but can cause cervical carcinoma and nasopharyngeal carcinoma. So there is similarities in the molecular mimicry which induces autoimmune disease by and large, and it's mostly B cell rather than the T cells.
That's just a comment that's very interesting on the HPV side, because the genetic control of HPV is also in the MHC. We showed many years ago the involvement of DQ3, for example, in that. So maybe actually some of the MHC association in some of those diseases could be like the original description of the association, a virus-induced actually co-genetic control. So that's great.
So again, I will say, like to my wife, you are right.
If we pay attention at the possible resolution of depression and not the ignition of the process installation, not so long ago, when you would have a depression, your medic would tell you to go to the psychoanalyst, not to the psychiatrist. And then, in a certain number of cases, the depression would get cured just by psychological effect, meaning that neuron somehow can act on all this that you showed us. So what would be your hypothesis for this effect?
I don't have any experience in the effect of psychosis on psychoanalytic strategy on inflammatory processes, but this is possible. We know that there are different strategies that help resolving inflammation, including meditation, for instance, social support, so interaction with others and all of that. So this process may help. The way the mechanisms that are involved are not clear and are not clear to me exactly. So I'm unable today to explain to you how it works. But there are different data showing a bunch of data showing that this type of therapies or support can help resolving inflammation.
My point is that it may suggest that it starts in the neuron, not in the immune system at this point.
Oh, it could be both, actually. But,
yeah, of course, yeah. It can be both, yeah.
More questions? Maybe can ask the last question concerning another topic, which is the data on smell, which is very, very, very fascinating. The genetic of smell receptor is very complex. HLA is complex, but I think smell receptor are even more. And there are smell receptors in the HLA system. Is there any GWAS data that has pointed out the smell receptors system to both in either autoimmunity or psychiatric disorder that will substantiate this? hypothesis?
Unfortunately, nobody touched this issue, whether there is an association between smell and autoimmunity. Smell and depression was studied quite deeply. But smell and autoimmunity, there are now 7 papers in 7 different autoimmune diseases: systemic sclerosis, lupus, rheumatoid arthritis, undifferentiated chronic, in which in all of them they showed depression of smell associated with depression, but a defect in smell. So it was not studied. It's a new field. But the aromatherapy with lavender and orange is well known from 2,000 years by the Egyptian, that it gave you a good mood. Studies were done on college women, giving them the lemon or orange, and in Japanese old ladies. So it crosses actually ethnic groups. So it's very interesting, the correlation. It's a new aspect that I think that many of the people here should dwell into it and find how we can harness this information of the receptors, as well as how it affects actually the mood and psychiatric deviation, if I would say so.
I just read during the session in the New York Times health section that the loss of orange smell is actually one of the first signs of Alzheimer's disease.
So not only that, but it's a first sign of dementia. It's the first sign of family members who developed Alzheimer, they lose. It's the first sign of Parkinson's disease. So you can predict loss of smell that you will develop the disease. And it's not a very complicated way to measure the smell. So I can tell you that my recommendation to my student, the male student, I tell them, if you tend a woman for the first time, a girlfriend, and she doesn't smell, leave her. She will develop depression.
You know, mating is also based on smell receptor
Correct.
and MHC. So I think we should thank very much all the speakers and all the audience for the discussion.
Thank you very much. I enjoyed very much. Thank you very much.